So, Akash, first you present till the history and of the history, and then we'll
Okay.
come back to the first slide and discuss slide by slide, and then
Okay, sir.
we'll go on to discuss the like present examination part. That way, is it okay
Okay.
for you?
Yes, sir. Yes, sir. Yes.
Respected and beloved members of the White Army, welcome you all for the comprehensive clinical class of surgery. Today we have a special case presentation, very rarely presented by any students nowadays these days, but it's very important from the exam point of view, and also commonly seen in our clinical practice. That is gastric outlet obstruction, many causes. So we will be discussing it through a voluntary case presentation by Mr. Aakash Kumar Iyer, uh, undergraduate from Sri Venkateshwara Medical College, Pondicherry. Welcome to you, Mr. Aakash.
Thank you, sir. Thank you for the opportunity.
Really appreciate your interest and well preparedness for this presentation. I know you have already completed the examination. Even then, you are very eager to present this case. It's very much appreciated. Your kind gesture to help your juniors and others is really appreciated. Okay, so with that, let's start the presentation.
Yes, sir. Thank you, sir. Is my screen visible, sir?
Yeah.
Good evening to one and all. My patient is a 58 years old male, Mr. XYZ, hailing from Hariyur, who is a mason by occupation, belonging to the lowest middle socioeconomic class. He came with the chief complaints of abdominal pain for the past 5 months and vomiting for the past 2 months. Patient was apparently asymptomatic 5 months ago, following which he has developed pain in the upper part of the abdomen, which was insidious in onset, dull aching, intermittent in course, periodic with pain-free intervals, non-radiating, aggravated on food intake, and relieved on vomiting or on taking medication. However, for the past 1 month, it is continuous in course and is not relieved on vomiting. The patient also complains of vomiting for the past 2 months, which was insidious in onset, few minutes after the food intake, spontaneous, non-projectile, non-bilious, not blood-stained. The vomitus contains undigested food particles, but the patient says he can tolerate water intake. The patient also complains of reduced frequency of bowel movements, which occurs once in 3 to 4 days. He also has complaints of fullness after meals. He said he used to eat 7 to 8 idlis initially, but now he feels full after eating 2 to 3 idlis. The patient has lost 8 kgs in the past 2 months. Initially, he was 72 kgs, but now currently weighs 64 kgs, and the patient also has loss of appetite. The patient complains of easy fatigability and generalized weakness in doing his daily activities. There is no history of hematemesis, melena, or jaundice. There is no history of mass per abdomen, ball rolling movements. There is no history of back pain, no history of abdominal distension, chest pain, hemoptysis, or bone pain. There is no history of chronic medication. There is no history of heartburn, regurgitation, or water brash. Past history, the patient is not a known case of diabetes, hypertension, asthma, epilepsy, coronary artery disease, or peptic ulcer disease. There is no history of similar complaints in the past. There is no history of any previous surgeries or blood transfusion. Personal history, the patient consumes a mixed diet. The patient has complaints of reduced frequency of bowel movements and reduced bladder movements. He has a normal sleep-wake cycle. He is not a smoker or alcoholic, and there is no history of any other addictions. In the family history, there is no history of similar illness in the family. There is no history of any other cancers in the family. Summary, my patient is a 58-year-old male of lower socioeconomic status who had chief complaints of upper abdominal pain for 5 months, which was periodic in nature with intermittent pain-free period, which was relieved on vomiting or antacids and aggravated on food intake. For past 1 month, the pain is dull aching and continuous in course, and it is not relieved on vomiting. associated with vomiting, which was spontaneous. Few minutes after the food intake, the vomiting used to occur. The vomitus is non-bilious, not blood-stained, and it contains undigested food materials. There is also history of early satiety and constipation, along with easy fatigability, and the patient has significant weight loss and loss of appetite. And the patient also has decreased frequency of bladder movements. There is no significant past or family history. I suspect it to be a case of gastric outlet obstruction of malignant origin, and I'd like to confirm it by examination.
Wonderful, wonderful presentation, Mr. Aakash. Okay, so very good presentation. So let's go back to the first slide.
Yes, sir. Thank you, sir.
Your examiners must have been very much impressed if you are presented like this. There's no doubt you will score really well in your practical examination. So you can expect the best, okay, in results.
Thank
Aakash?
you. Thank you. Yes, sir.
Okay, so anything in, yeah, show me the slides, please. Okay.
Yes.
So anything contributory in your demographic details to the
Yes, sir.
diagnosis?
Yes, sir. The patient is a 58-year-old male. He is an elderly male, and he is
Not say you can't say elderly. Okay, elderly.
Okay.
When do you say elderly in India?
Mostly after 70 years, 60 or 70 years.
65. Okay, more than 65.
Okay.
In outside it's 60. Okay, so elderly.
Yes.
Okay, so every terminology has its own what to say importance. Okay, so can't loosely use those terminologies. Okay.
Okay, sir.
So
Yes, sir.
58-year-old gentleman. Okay. So
Okay,
it is relatively old age in the sense. Okay. So
yes,
in that age, what are the common problems?
So usually a gastric carcinoma, a gastric ulcer is common in the old age. Sir.
Malignancies are more common, right?
Yes.
Okay. Old age means we think more in terms of malignancy, whereas in a younger age group, we think in terms of more benign conditions. Okay, that's one age. And anything else? Occupation you highlighted.
Yes, sir. The socioeconomic status of the patient, sir. He belongs to a lower middle socioeconomic status. Usually in lower middle socioeconomic status or lower socioeconomic status, distal gastric cancers are common due to H. pylori infestations.
Anything else? Anything else? These occupation to have got to do with etiological factors for malignancy?
The occupation, in case of any higher occupations or affluent societies, there can be due to GERD or obesity, the patient may develop carcinoma or gastric ulcers.
Okay, so more than that,
names why it will be there only, no, one after the other.
So sorry, I had to. One is one second.
Yes.
Someone is
One, no.
Okay, fine. Sorry for the disturbance. Okay, so Masons. So all these people are more those who are working under the stress and all. And these people are more these taxi drivers, Masons. All those people are more commonly having these habits like smoking and etc. Right? Yeah,
yes, sir.
That's also again contributory. So in that way, occupation may be related. I'm not pinpointing anything like that, but relatively. Okay, so we can get some suspicions like that, and we can ask more about that. So again, lower socioeconomic class has got to do with something with the relation with the carcinoma stomach, right? Then what are the possible complaints? Here you told abdominal pain for 5 months and vomiting for 2 months. So what are you in your mind when he says there is abdominal pain for about 5-6 months and there is last 2 months he's having vomiting? So what all comes to your mind now?
Sir, first abdominal pain, he said it is in the upper abdomen. So I think of pain arising from the foregut structures like esophagus or stomach, or the gallbladder or the liver, sir.
Well, then why vomiting after suddenly in 2 months, last 2 months?
So vomiting may be due to as a result of the obstruction of the gastric outlet, sir. That may cause vomiting.
Can you say a gastric outlet at this juncture?
No,
Only
sir.
gastric outlet obstruction causes vomiting?
No,
Along
no,
with
sir.
pain
No, sir.
abdomen? Then?
No, sir.
Okay,
An
so what I
ulcer.
mean to say is, see, I'm not finding out any mistakes, but at this stage, have wide thoughts. Okay,
Yes.
Don't limit yourself. You already know the diagnosis, so you are getting biased. Okay, when answering, don't do that.
Yes.
Okay,
Yes.
so at level, history level, keep all the options open. Okay,
Yes.
so that you get more things to discuss, or you need not be so rigid. Okay,
Okay.
clear?
Yes.
Next slide.
Yes, sir.
Okay, tell me if it is a case of carcinoma stomach, what are all the possible complaints with which a patient can present to you?
Sir, in case of carcinoma stomach, the patient may have a mass for abdomen, sir, initially.
Okay.
Then he may have anemia, asthenia, and anorexia, sir. Loss of weight and loss of appetite will be there, sir.
3A's. I wanted to pinpoint 3A's. Looking at the patient only, you can make out or suspect is having some stomach carcinoma. How? These three A's. That is anemic, the asthenic, very cachexic, and third thing is the anorexia.
Anorexia.
Okay. What else?
Then the patient may have complaints of blood in vomiting, sir. Hematemesis or melena can be there.
Why is that?
Sir, because in case of any gastric carcinoma, it can lead to bleeding, sir. And the bleeding may come as hematemesis, or it may pass through the intestine to form melena, sir.
Okay. So, okay, there are so many complaints. I'll make it easy for you. Okay, for the benefit of the members. Just remember it as stomach. I'll give you a mnemonic. Stomach.
Yes, sir.
Most important and most common presentation is silent presentation, right? It's asymptomatic. Many times they come in the advanced stage only. The initial stage, they won't have any symptoms or they won't come to you. Correct?
Yes.
So, first is silent. That is asymptomatic.
Yes,
T for tumor. They can, like you said, they can present with a mass.
Mass for abdomen.
Mass or tumor. Remember it as tumor. Then ST. O for in your case, obstruction. Okay, they can come with outlet of obstruction. And M for
melena, sir.
Very good. Melena. Why melena? These ulcers slowly bleed. Okay, very small amount of bleed. So they accumulate, and they cause melena. Okay, that's it. Then A for
anemia. Those three A's, sir. Anemia, asthenia, and anorexia.
Yeah, weight loss. That is asthenia, and they can also complain of
anorexia, sir.
Yeah, loss of appetite. Okay, or early satiety. More than loss of appetite, they will tell you in early satiety. That is the classical feature. Okay, like you said, 8 idlis at the in the beginning. Now he's having only 3 idlis. Okay, early satiety. Then C for
cachexia.
Very good. Cachexia, or even they can have constipation. Okay.
Constipation.
Then H for
hematemesis.
Wonderful, Aakash. So this is the you can remember this way. Okay. So and I always tell my juniors or the students out there, anything in any case, follow the rule of 3 C's. Okay. You will not miss out anything, especially in chief complaints and the history of presenting illness. Follow the rule of 3 C's. The first C stands for the case or the cardinal symptoms of a system. See, for example, now he's having pain abdomen with vomiting. What is the case?
Probably an ulcer case, gastric ulcer or the duodenal ulcer.
Something, not ulcer. It's something related to per abdomen, right?
Yes, sir.
Abdominal. All the symptoms are related to per abdomen. So, per abdominal case. That's one thing. Case is confirmed. Next, second C is the cause.
Yes.
Okay. Anything in the chief complaint also, they can complain of some etiological etiology, or even in the HOPA, it's very, very important to rule out all the possible etiologies. for that particular
Yes.
case. Second C is cause, and third C is the complications. Okay, what are the complications of every condition? They can just directly come with jaundice, for example.
Yes.
Correct? It's complication of any benign disease or even the malignancy. So in these three steps, three C's. First is the case, second is the cause, third
Cause.
thing is the complication. Even in the HOPA also, if we just follow these three steps, no, we'll not miss out anything. Clear?
Yes. Yes.
Okay. So stomach, that the mnemonic is there, and okay, HOPA. Can you please tell me the significance or what you really happening here with this patient? You're telling this
Yes.
patient is having pain in the upper abdomen, and how can a pain be insidious in onset? Akash, what do you mean by insidious in onset?
Sir, it
How
was
can anyone have an insidious pain? What do
it
you
was
mean by
gradually
insidious?
insidious. It is present for a very long time, sir, and it
Okay.
is gradually progressive, sir.
Okay, fine. So what insidious exactly means? There is a discrepancy between the onset and the notice. Okay, for
Yes.
example, breast lump or some hernia or some tumors, we say insidious. But the pain, even first at first pain only you can notice that, right?
Yes.
Okay, it cannot be happen like pain was there since 1 year and now he noticed the pain. Can it happen that way?
No, sir. No.
Okay, so be
Yes.
careful while using this insidious in onset and all for pains.
Yes, sir.
Okay,
Yes.
insidious in onset, dull aching, intermittent in see. What is this? Why this periodic pain is there
So
in this case?
periodicity is because of in case of gastric ulcers, there will be a periodicity which will be maintained, sir. The patient will have pain for a period of time, and
Why?
he
Why
will
I'm
be
asking?
so because the ulcer will create, sir.
Very good, very good. Ulcer will somehow heal. Okay, on their
Yes,
own. So they will have pain-free time for some
yes,
okay, some duration. Okay, and again the ulcer will reoccur because of the etiological cause is persistent. So again they will have ulcer and this will continue. This is why they'll have periodicity.
periodicity.
Clear?
Yes,
Okay.
yes.
Non-radiating, aggravated on food intake. So how do you clinically differentiate between most important question? Okay, how do you clinically differentiate between gastric ulcer and duodenal ulcer?
Yes, sir.
Clinical.
A gastric ulcer will it will be aggravated on pain, sir, and aggravated on food intake. Aggravated on food intake, sir. Whereas in a duodenal ulcer, the food intake will relieve the patient of the pain, sir. And
Why? You know the reasons, right? For everything, you should know the reasons. Okay. All this theoretical. I'm not going to details, but please know the reasons for everything. Why there is hunger pain and why there is a on food intake. The why pain aggravates. For everything, you should know the reasons. Okay.
okay, yes, sir.
Okay. Next point.
Next point, a patient with duodenal ulcer will be well nourished, sir. He will be either obese or well nourished. Whereas in a gastric ulcer patient, because food intake will cause pain, he will have fear of having food and
Okay.
he'll be thin built, sir.
Very good. Next.
And in case of gastric ulcer, there is increased risk of bleeding, sir. The gastric ulcers may bleed, whereas duodenal ulcers usually do not bleed, sir. And the gastric ulcer has a higher chances of malignant conversion, sir.
Which gastric ulcers bleeds usually?
Posterior gastric ulcers will bleed, and the anterior will perforate, sir.
Very good. So, which is the most common artery involved?
Left gastric artery, sir.
No, not really. This is a major blood supply. It's gastroduodenal artery. Okay, gastroduodenal. Clear? So, okay, what other points? Good, you're answering really well.
And the pain, usually in case of gastric ulcer, the patient will induce vomiting, sir, to relieve him of the pain.
Anything else?
That's also.
Okay, now earlier the pain was intermittent. now the pain has become continuous. Why?
The pain has become continuous. Maybe it could be because of the infiltration of the malignant cells into the nerve supply of the stomach, sir. Or the irritation of the viscera may cause continuous course of pain, sir.
Irritation, and one more thing is the what happens? The distension of the viscera. Okay.
Distension of the
Not irritation.
yes.
Usually distension of the viscera. Okay, that is
Okay,
causing
sir.
the heaviness or the dull aching pain. Okay.
Yes, sir. Yes, sir.
Vomiting or taking. Then patient complains of vomiting for insidious onset few minutes after. Why this few minutes after food intake?
Sir,
it's
initially, yes, sir. Initially, the patient, in a patient of gastric outlet obstruction, he will have vomiting towards the evening, sir. But as the obstruction increases, the patient will have vomiting after every meal, sir.
So what kind of vomiting will be there usually in a gastric outlet obstruction?
Usually in gastric outlet obstruction, there will be a projectile vomiting, sir.
Okay, what do you mean by this projectile and non-projectile?
So in case of projectile, the vomiting will be preceded by retching, sir, and the vomitus will be thrown away from the place of the patient. And in case of non-projectile,
no, you are getting confused. Projectile will not have this any pre-nausea or anything. Directly they'll have vomiting. Okay, correct?
Okay. Yes, sir.
Non-projectile, they will have preceding nausea.
Yes.
Okay.
Yes, sir. Okay, sir.
Okay. What are the other causes for projectile vomiting? One is gastric outlet obstruction, any pyloric stenosis.
Yes.
So second, any other condition you know?
In case of increased intracranial tension,
Very
any
good.
brain tumor, there will be projectile vomiting, sir.
What are causes for bilious vomiting?
Bilious vomiting, it can be due to cholecystitis, acute or chronic cholecystitis, sir.
And
any small bowel obstruction.
Very good, very good. Okay. 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 Well, fine. Next. Okay. What's happening here? Please tell why. Reduced frequency of bowel movements.
Yes,
why?
Sir, because the patient, because he is vomiting everything he is eating, he has changed his diet to completely to liquid diet, sir. And he is also not since because there is an obstruction, there may be constipation, and even because of dehydration the patient has, so therefore he may have reduced frequency of bowel movements, sir.
What do you mean by constipation?
Constipation, the patient will pass stools either once in 3 days or 3 times in a week.
Wonderful.
Yes, sir. And the stools will be hard and formed, and or the patient will have difficulty in passing the feces.
So once in 3 days is considered to be normal. Okay, in India, one day if you don't pass, we say come and tell I am having constipation, right? That's not so.
Yes.
No, that's not. But again, having said that, all these bowel motility, everything depends on our food habits also. Okay, all these definitions based on the Western world. Okay, but they eat mainly this fatty food which is not easily digested, meat, breads, and also they for them once in 3 days maybe normal. But for us, we eat more of carbs with rice, all those things, so which easily gets digested. So for us, once in a day is considered to be normal. Correct? So all these are relative. Okay. So next one, complete fullness after meals.
Yes, sir.
Why?
Because
that's
the fullness.
Early satiety, you meant to say, or
that
bloating sensation.
He has early satiety, sir.
Okay. So why is that early satiety?
Early satiety is because due to the malignant infiltration of the muscular layer of the stomach, sir. So it cannot distend, sir. So therefore, the patient will have early satiety.
Very good. The lumen becomes narrow and narrow. So capacity, storage capacity is less. Okay. So they will have early satiety. Which conditions you will find increased satiety? Since you're answering well, I'm just debating here and there. Okay. Don't mind, Aakash.
Yes, sir. Increased satiety in case of duodenal ulcers, sir. And
most commonly seen condition in our society.
So you mean increased Diabetes, sir.
Diabetes mellitus. Okay, they
Yes,
have
diabetes
increased satiety and increased thirst also. So
Yes.
polyphagia, polydipsia,
Polyuria.
and
Polyuria.
polyuria. Okay. And also in hyperthyroidism, correct?
Yes.
They'll
Yes.
also have increased appetite. Okay, so just to know the things. So
Yes,
a patient has lost. What is this significant weight loss?
Significant weight loss is so loss of weight of 10% of the initial weight in 6 months, sir.
Okay, and the newer definition, that is 5% in 3 months. Both. Okay.
sir.
The older
Yes.
examiners may agree with you, but the recent one is 5% in 3 months.
5% in 3 months. Yes, sir.
So if they already documented the weights and all, then fine. You can mention that this is the better way of presenting actually with the weights. Or else how do you say? And one more thing is, what's more important here is more than significant. It's unintentional weight loss.
Yes,
Correct?
sir.
That you
Yes,
should have
sir.
been mentioned. Okay.
Okay.
So some people
Yes.
have voluntarily made have lost 10 kgs or 20 kgs. Is it relevant?
No, sir. No.
Okay. So what is important is more than significant. It is unintentional weight loss.
Okay, sir.
Okay, no?
Yes, sir.
Since you cannot find any mistakes in your presentation, I'm just pinpointing here and there. Okay, don't mind. Okay.
Yes. Okay, sir.
I'm really happy with your presentation actually. So
Thank you, sir.
I'm trying to pull your leg. So next, he also complains of easy fatigability and generalized weakness in doing. Why is it this?
So it is because of anemia and asthenia. The patient
Chronic
has
blood loss.
the
Anemia two causes. One is chronic blood loss. Second thing is
because there will be iron deficiency anemia, sir.
nutritional.
Nutritional. Yes.
Okay, nutritional, and second thing is chronic blood loss. Okay, so
Yes,
these are the constitutional features of that: fatigue, weakness. Yes. Next, good. Please explain why all you have asked for all these things.
Yes, sir. Hematemesis and melena are seen in gastric carcinoma and also in gastric ulcer. And to rule out jaundice, because if there is any metastatic nodules to the liver or any nodules which may be due to carcinoma stomach, there may be nodules at the porta hepatis which may compress the common bile duct leading to jaundice. Mass per abdomen is because of the serosal infiltration, which may present as a mass per abdomen, and ball rolling movements is because of movement of the stomach against the obstruction, if it is visible or not. History of back pain is because the patient may have infiltration of the malignant cells posteriorly into the pancreas, and this will cause lower backache in the patient, and it is not related to food intake. Abdominal distension due to if there is any peritoneal metastasis, chest pain and hemoptysis to rule out any metastasis to lung, and bone pain to rule out any metastasis to the bones. Chronic medication, I wanted to rule out chronic medication because the patient may have some other musculoskeletal conditions like rheumatoid arthritis, for which the patient may take NSAIDs, or the patient may also be taking proton pump inhibitors for the ulcers. And to rule out peptic ulcer disease, I have asked for heartburn, regurgitation, and water brush.
Anything other thing to do with this chronic PPI? What is proton pump inhibitors? Chronic consumption?
I didn't get your question, sir.
In any way, this chronic consumption of medicines like proton pump inhibitors related to this case?
If the patient previously had any peptic ulcer disease, he may be taking this, sir.
Okay, he's taking. So, is it anyway relevant for your diagnosis? I'm asking.
No, sir.
It is.
Not.
It is. How? Chronic, see, proton pump inhibitors, what it does?
It will decrease the acid output, sir.
Okay. So, what it is called?
It will act hydrogen pumps, sir.
No, what is it? Decreased output of acid is called? Achlorhydria. That itself is a etiology, one of the causative risk factor for carcinoma stomach.
Yes.
Correct?
Yes, sir.
In that way also it's important. It's an etiology. NSAIDs
Yes.
and chronic consumption of PPIs, all those are etiology. So you should have ruled out. Next, no heartburn, regurgitation, GERD. What do you rule out?
I wanted to rule out GERD, sir, heartburn and
See,
regurgitation
what
and
has happened is,
water
yeah,
burn.
you asked so many questions, but all haphazardous. That's why I told in the beginning. So it should be
Yes,
in an
sir.
order. First,
Okay, sir.
you prove that it's a stomach origin, some disease originating from the stomach. Then prove that it's a malignant. First, malignant. Second, okay.
Yes.
Then
Yes, sir.
go for the if you prove that it's a malignant, then look for any metastasis or the spread. Okay, by
Yes.
asking. Then what may be the probable etiology cause?
Yes, sir.
Okay, so you have to here it has all become haphazardous.
Okay, sir.
Correct?
Yes, sir.
Okay, go in an order so that you will not miss anything.
Okay, sir.
First, if, it's a stomach, then stomach carcinoma. Then that is again, if we have to prove that it's malignant. Then the features of metastasis. Then what may be the probable etiology.
Okay, sir.
Okay. Okay. Next.
Yes.
Okay. Past history. What previous surgeries you are interested to know?
Sir, if there is any previous history of gastrectomies or there is previous gastrojejunostomy, there may be recurrence of the disease, or there may be recurrence of the cancer, which occurs in within 2 years of the surgeries.
And earlier days, this again, truncal vagotomy. Earlier days
Yes.
they used to do for gastritis, they used to do truncal vagotomy. That again causes what? Just now I told.
Achlorhydria, sir.
Okay, that it's also can cause. So nowadays,
Okay.
how do they prevent? What do the treatment for peptic ulcers?
They do highly selective vagotomy, sir.
What is that highly selective vagotomy?
They remove the criminal nerve of Grassi, sir. And
what is highly selective? What is selective? Nerve fibers which are supplying the parietal cells at that level, they cut. Okay, not the entire, not the trunk or the branches, but only the nerve fibers at the parietal cells only. So okay, they are. So which is preserved? Which nerve is preserved?
Sorry, sir.
You told criminal nerve of Grassi is what is that? It should be ligated, right? So which nerve should be? What is nerve of lateral jet?
I don't know, sir.
Oh, fine. Next. Okay, what kind of diet is dangerous here?
The patient used to have a spicy diet, sir. Salty, spicy, and smoked diets.
How it is causing this carcinomastoma?
Sir, it will lead to the formation of nitrosamine compounds, sir, which decreases the level of antioxidants, thereby leading to gastric carcinoma.
Wonderful, wonderful. So reduced. Why this reduced bladder movements?
So since he is vomiting, sir, for 2 months, he is having dehydration symptoms also, sir. So there is decreased urine output, sir.
What is the difference between dehydration and hypovolemia? Correct? Question is correct?
Yes, sir.
No, both the same. Both are same or different?
Different only, sir.
Okay, what's the difference then? Dehydration and hypovolemia. There are 2 compartments in the body, correct?
Yes, sir.
One is, there are 3, but mainly one is intravascular and one intracellular.
Yes.
Loss of fluid from intracellular compartment is dehydration. Whereas loss of fluid from intravascular compartment is hypovolemia. Okay.
Okay.
So it's not a smoker, alcoholic. You need not, if it's not, you need not mention specifically.
Okay.
No addictions, because addictions are hundreds. You can't mention everything. If he is addicted to anything, you can mention about that. Clear?
Okay. Yes, sir.
Okay. Okay. Why do you ask about in the family, the same thing?
So because hereditary, there is a familial predisposition in case of stomach cancer, sir, and it usually occurs due to mutation in the E-cadherin gene, where there is 10% of predisposition in gastric cancer, sir. And other cancers like colonic cancers, or in case of Lynch syndrome, there may be polyps, sir. So to rule out that, we are asking for this, sir.
And in this gastritis, okay, this peptic ulcers can also be familiar.
Okay, sir.
Next. You want to know about the personal history? You want to know about anything, blood group, anything?
Yes, sir. The blood group A will have a higher risk of gastric carcinoma, sir.
Why?
Because in case of blood group A, there is increased A mucopolysaccharides, which has increased affinity. Yes, sir.
Propensity for the carcinogen, yeah, affinity.
Carcinogenic
Very
element.
sensitive
Yes,
for the carcinogens, correct?
Yes, sir.
You're excellent, man. You're excellent. Okay, good.
Thank you.
So, whereas blood group O is more, the people with blood group O are more prone for having peptic ulcer.
Peptic
Okay.
ulcers.
Okay,
Yes.
whereas blood group A will have carcinoma.
Carcinoma. Yes, sir.
Okay, next.
Examination, sir.
So no, in this summary, see, you need not include so many things, so many unnecessary things. Okay,
Yes.
50-year-old male, okay, low socioeconomic status, okay, with chief complaints and all, don't need to write chief complaints here, all those things. Presented with upper abdominal pain for 5 months, and all these things which was periodic pain, which was intermittent, all this, again, periodic means again intermittent. What is that? What do you mean periodic and intermittent?
Okay, sir.
Okay, all these things
Yes,
not
sir.
required, necessary. And having now dull aching pain, continuous in course, not relieved by vomiting. So this much is unnecessary. So many things are there. I don't want to go in detail. Okay.
Okay,
So
yes, sir.
keep a brief summary.
Yes, sir.
The only positive relevant points.
Okay, sir.
Okay, it's a gastric outlet obstruction. So what is a feature in favor of gastric outlet obstruction?
There is vomiting,
One
sir.
point.
Vomiting and early satiety, sir.
Early satiety is not a feature of gastric outlet obstruction. Yeah, vomiting. As soon as he eats something, he will have within few. Correct. He will have vomiting.
Yes, sir.
Correct. That is in more favor of gastric outlet obstruction here. So what are the features of
Okay.
malignancy here?
Malignancy features are starting from the age of the patient, and there is sudden loss of periodicity in the pain, and there is also presence of early satiety. The patient has significant unintentional weight loss.
All this can happen in benign condition also, right?
There is loss of appetite also, sir.
Loss of appetite, gastric ulcer. Chronic gastric ulcer.
Yes, sir.
Causing cicatrization and all this, or weight loss, everything can be there, no?
Yes, sir.
So at this juncture, can you really make out whether it's a malignant or benign? Just with some, what is that, weight loss is there, loss of appetite is there? No, you can't.
Okay, sir.
Correct? So that's why I told.
Yes, sir.
Always
Okay,
have, okay, don't just jump onto conclusion at level of history at least. Okay?
Yes, sir. Yes,
These are mass for abdominal kind of graveyards. Okay, it's a, that's why it's called Pandora's box or magical box. We really don't know what's happening inside. So keep your what diagnosis at the end of examination.
Yes, sir.
This is not a very straightforward case like a hernia or a breast lump or thyroid. Okay, mass for abdominal is relatively tricky ones.
Yes, sir.
Next, examination.
Yes, sir. The patient is conscious and oriented to time, place, and person. The patient is moderately built and nourished and is thin built, and he has a BMI of 20 kg per meter square. He also has signs of dehydration, such as his skin turgor is lost. He has a dry tongue and there is decreased urine output. The patient has pallor but there is no icterus, cyanosis, clubbing, lymphadenopathy, or edema. There is no fullness in the left side of the axilla or left side of the neck. The patient has pulse of 86 beats per minute, which is full in volume. There is no specific character in the right radial artery. The patient has a BP of 100 by 70 millimeters of mercury in the right upper arm with the patient in supine position. The patient has a respiratory rate of 16 cycles per minute, which is abdominothoracic in type, and the patient is afebrile.
So here is the build is very important. Build and the
Yes.
nourishment very important. Okay, and
Yes.
yeah, dehydration you are told, and the pallor is there. What is this? No fullness in the left axilla or left neck.
I am looking for virtuous node and Irish node, sir.
What is this
Troisius
virtuous node?
Virtuous node is the enlargement of the left supraclavicular lymph node on the left side, sir. It is also
Why?
known as Troisius sign. So because the malignant cells from the stomach will enter into the cisterna chyli and through the esophageal hiatus, it will enter the thoracic duct. The thoracic duct will enter the internal jugular vein at the junction of internal jugular vein and the left subclavian vein. Due to the increased large size of the malignant cells, there will be retrograde flow of the malignant cells into the virtuous node, sir.
Nearby adjacent lymph node, that is left supraclavicular lymph node.
Yes, sir.
Reflux, because it cannot pass, the malignant cells are so big, it cannot pass to the capillaries. So it gets refluxed back to the nearby whatever lymph node. That's why only selectively left supraclavicular lymph node gets enlarged. Okay. So sometimes they can have, it's very rare, sometimes they can have a rare metastasis to the, some cases have been this thing documented. They can have a left anterior axillary group of lymph node. That is called Irish lymph node.
Yes, sir.
Okay. Good. Anything else? You are told about Troisius sign. What about Troisius sign? Have you looked for it?
Troisius sign is, yes, sir. It is the superficial migratory thrombophlebitis, sir. It is usually seen in cases of pancreatic and gastric carcinomas.
Okay. Another Troisius sign?
It will be seen in hypocalcemic tetany, sir.
So can we expect it here?
Yes, sir.
How?
Sir, because in case of the patient will have a metabolic abnormality wherein he will have a hypokalemic, hyponatremic, hypochloremic, metabolic alkalosis
One
with
more,
paradoxical
hypocalcemic.
Yes, sir. Hypocalcemic will also be there, sir. Yes, sir.
Hypochloremic, hyponatremic, hypokalemic, and hypocalcemic.
Calcemic, yes, sir.
Correct. Hypocalcemic, metabolic.
Alkalosis with paradoxical aciduria will be present, sir.
Okay, you know what is that paradoxical aciduria, how it happens, everything. It's very good concept. Everyone must know. Okay, why everything, why there is a hyponatremia, why there is hypokalemia, everything. It's a beautiful concept. I don't want to go into detail now. Okay, so everyone must know. This is a definite question. What is the metabolic what is derangement seen in gastric outlet obstruction? Definite question. Correct. So we should know this. Good. Next, vitals are all okay. You can expect, because some dehydration is there, you can expect some tachycardia or hypotension. Okay. And I don't like the temperature cannot be afebrile. All those things you should correct. Okay. How can a temperature be afebrile? Patient can be febrile or afebrile. How can temperature be afebrile? Okay. Temperature is always 98, 99 or whatever it is. You should measure and write. At least at UGs. You can't write temperature afebrile. Okay. Next.
Okay. This is the picture of the patient, sir.
Okay. What are the causes for distension of abdomen?
Distension of abdomen may be due to, physiologically after food, there may be distension of abdomen, sir. And pathologically in case of gastric outlet obstruction, because of chronic duodenal ulcer with cicatrization or a carcinoma head of the pancreas may cause a epigastric mass, sir. And sir.
Okay. Tell.
And in case of gastric carcinoma, there may distal gastric carcinoma, there may be a gastric outlet obstruction, sir. In case of chronic pancreatitis, trichobezoar, and that's all, sir.
So in general, the causes for distension of abdomen are, remember it as 7 Fs. How many?
Okay, 7 Fs.
Okay, you rule out one by one. When you on examination, you are seeing a distended abdomen like this. So first,
Yes,
one by one, rule out 7 F's, and that will cover everything. First and
Yes.
foremost, most common cause for distension is fat.
Fat. Yes,
Correct? Obesity.
yes, sir.
That is ruled out here. Second thing
Yes,
is
sir.
the fetus. Ruled out
Fetus.
here.
Yes, yes, sir.
Okay. Third thing is the fluid.
Fluid.
Fluid means ascites. Correct?
Yes, sir.
That
Yes,
is
sir.
one of the possibilities here.
Yes, sir.
Fourth one is the flatus. That is gaseous distension.
Yes, sir.
That's a possibility here.
Yes, sir.
You're telling some obstruction is there. You're telling no. You still we don't
Yes,
know
sir.
where is the level of obstruction. Okay. So it
Yes,
could
sir.
be a small bowel obstruction. So there can cause a distension of the gaseous distension of the abdomen. Okay.
Okay.
Fourth.
Yes.
Fifth is feces. What is feces? It is constipation. It can cause
Constipation.
loaded colon loaded with feces. That can
Yes,
also
sir.
cause distension. It's also again possibility here.
Yes, sir.
And sixth and seventh is the full bladder.
Fetal growth. Full bladder. Yes.
Full bladder. Even distended bladder also mimic like a distended abdomen, the lower abdomen. Seventh
Yes,
one
sir.
is the what is that, Akash?
Fetal growth, sir.
Fatal tumors. Okay.
Yes.
Fatal
Yes.
mass or fatal tumor. That's again possibility here. So we have to rule out
Yes, sir.
4 again. Out of 7, here there are 4 possibilities here now. Okay. Fluid,
Yes.
flatus, and what is that? Feces and
Feces.
fatal mass. One by one, we'll rule out now
Yes.
on examination. Next.
Yes.
Good.
Patient's consent has been obtained and he is examined in a well-lit room. The patient is adequately exposed from just above the xiphisternum to the mid-thigh in supine position with arms by the side. On inspection, the patient has a flat abdomen. The umbilicus is central and inverted. There are no umbilical deposits. All the quadrants of the abdomen move equally with respiration. There are no scars, sinuses, or dilated veins over the abdomen. Visible gastric peristalsis was seen. Fullness is noted in the epigastric region. Hernial orifices are normal. External genitalia was normal.
Okay. So, okay, we'll finish it off. Inspection. Okay. So you have covered everything. Will you come back?
Yes, sir.
Okay. Abdomen. First thing is the contour of the abdomen. You will always comment about the contour or the shape of the abdomen. Here is flat
Contour.
abdomen, not distended. There is no
Flat
local.
abdomen. Yes.
You only tell fullness is noted in the epigastric region. Then you're telling flat abdomen. How can it be? Contradictory, right?
Yes, sir.
You can tell this upper abdominal distension is there, and the lower abdomen is supposed to be flat. That's better. How can you tell
Okay, sir.
abdomen is flat? You're telling. Then again, there is a distension in the upper abdomen. You're telling.
Okay, sir. I'll change it, sir.
Correct?
Yes, sir.
No. I'm just telling. See, all these are not mistakes, but how we in
Yes.
2 lines to contradictory statements.
Yes, sir.
That should not happen.
Okay, sir.
Umbilicus is what is the importance of umbilicus in your examination?
Sir, in case of if there is any metastatic deposits in the
Before
umbilicus,
that,
before that, if there is any free fluid in the abdomen because of peritoneal metastasis, there may be the umbilicus may be inverted,
shifted?
sir, and it will be shifted.
Shifted down. If there is ascites,
Yes,
what is the normal situation of the umbilicus? It's midway between the xiphisternum and the pubic symphysis. In case of
xiphisternum
ascites,
and yes,
they shift down, whereas in pelvic
shift
masses,
down.
they shift up.
Up, sir. Yes.
And in case of ascites, there will be umbilicus will be everted and
Everted.
stretched
Yes, sir.
for
Yes.
smiling umbilicus. Correct?
Yes, sir.
And what is this sign called? It's called Taniol's sign.
Annual signs. Yes, sir.
You know, no? Taniol's
Yes, sir.
shifting of this umbilicus up and down. Another thing is, then come now. What is the second point? Why you're looking at umbilicus is?
The metastatic deposits, sir.
What is it called?
It is called Sister Mary Joseph nodule, sir.
Okay, why is there? Why there is a selectively there is a metastatic deposit in the umbilicus?
So because the malignant cells from the lesser curvature, it will come into the lesser omentum, and through the lesser omentum, it will follow the falciform ligament or ligamentum teres Along that, it will come and deposit in the umbilicus.
Most of them not able to answer this point. Okay, accurately. Okay, through the ligament of teres or the what is it, falciform ligament spreads from the stomach to the where it joins near the umbilicus. So that is that's why there's a deposit near the that's called Sister Mary Joseph nodule. Okay. Next, you have written about the all movement of the abdomen with respiration, the skin over the this thing. Where just with the peristalsis, can you tell the site of obstruction? Looking at the visible peristalsis, can you tell where is the obstruction? How?
In case of a visible peristalsis, there will be movement of the peristalsis from the left to the right. In that case, we can infer that the obstruction is in the stomach. Okay. And if there is a step ladder pattern of peristalsis seen, there should be a small bowel obstruction. And in case of visible intestinal peristalsis, there will be a peristaltic movement from the right to the left.
Colonic, right to left. Wonderful.
Colonic.
Yes. Okay, wonderful answers.
Yes.
Good. So fullness is noted in the epigastric region. Hernial orifice is normal. External genital normal. One thing you missed in the inspection. What is that? Can you yourself can make out? This abdomen is examination, not just the abdomen. It includes the back also, Aakash. You need to examine the back. I can give hundreds of examples where we have missed the important diagnosis just by not examining the back. There is just a small sinus, adjacent to the vertebra, and there is a discharge. My diagnosis is done. What is that? I need not even palpate the abdomen. I just see a discharging sinus in the paravertebral region, and my diagnosis is done. What is that?
Don't know.
Pot spine.
Pot, yes. Okay.
Because it's a abdominal TB which is spread to the vertebra now, and this is vertebral TB is manifesting as a paravertebral sinus.
Okay.
So I will not just this small example. Okay, there is a lot of importance of examination of the back. So you should not miss inspection, palpation, both.
Okay.
Next.
Yes, sir.
And again, you can any visible impulses are there, and any peristalsis told, any dilated veins, all those things you can mention. The skin.
Okay. Sir. On palpation, the patient is asked to flex his hips and knees.
Any visible impulse was there here? Visible impulse?
Sorry.
Any visible impulse was there?
No visible. No, sir.
When can you expect visible impulses?
There may be a associated hernia may be present, so we can see a visible cough impulse.
Sorry?
In case of associated hernias.
No. That is cough impulse. That is different. It's not visible impulse.
Okay.
That is cough impulse. That's different. Visible impulse means with every pulse there is a impulse is seen.
Yes, sir. It can be if the tumor is anterior to the abdominal aorta, there may be a pulse, visible impulse.
What kind of it's a visible impulse is there. What type will confirm in the palpation, right?
Yes, sir.
So there could be visible impulse. Okay, should carefully notice palpation.
On superficial palpation, there was no warmth or tenderness, and the abdomen feel is soft. On deep palpation, a mass of size 4 into 5 centimeter was felt in the epigastric region, extending up to the right hypochondrium, with irregular borders, non-tender, smooth surface, hard in consistency. I was able to insinuate the fingers between the mass and the subcostal margin. The mass moves with respiration and can be moved in both horizontal and vertical directions. The mass becomes less prominent on head raising test, but it becomes prominent on the knee-elbow position, and the mass is non-pulsatile. No other masses were felt in the abdomen. Succussion splash was positive. There is no organomegaly. Hernial orifices are free, and the external genitalia is normal.
Now the question is mass you have explained well.
Yes.
Now what is this less prominent on head raising test and prominent on knee elbow position? What is this?
Sir, it is to differentiate between a parietal swelling and the intra-abdominal swelling, we do a head raising test. Since there is a
it's called
mass in the abdomen,
Carnet's test.
Carnet's test. Yes, sir.
Okay. So now the question is, so okay, you say this is a intraperitoneal, right?
Yes, sir.
Your inference is intraperitoneal.
Yes, sir.
So it's not falling down, it's not becoming prominent on knee elbow position.
Yes, sir.
What it does mean?
It could be a retroperitoneal mass, sir.
Only
Sorry, sir.
peritoneal, it cannot be peritoneal mass. If it is adherent, it will infiltrate to the posterior structures.
Yes, sir. Then it will be, if it is adherent to posterior structures like the pancreas, then it will be less prominent, sir, on knee elbow position.
Correct. So think and see.
Yes, sir.
For your undergraduate level is more than enough, but always think. Why it's happening like this?
Okay.
What is this? Everything for every point. Think before you ink. If you have
Okay,
written
sir.
something, means you're committed. You should know
Yes.
everything about that.
Okay, sir.
And non-pulsatile, what you are expecting in a intra-abdominal, you're telling in the intra-abdominal, what your pulsatile mass you're expecting?
So it could be a abdominal aorta aneurysm can be present, sir. It could be, it has a expansile
It's the retroperitoneal, not intraperitoneal. You're telling it's a,
yes, sir.
You are telling it's intraperitoneal mass.
Yes, sir. It is intraperitoneal, sir.
Then you should have written that separately. There is no visible impulse or palpable impulse in the epigastric region. That's fine. Then I'll ask you what are the types of impulse. Then you will tell expansal impulse and transmitted impulse.
Transmitted impulse. Sir.
Here we can get transmitted type of impulse. That's from the pulsating aorta. If the mass is overlaying the aorta, then it can transmit the aortic pulsation.
Aortic pulsation.
Can be palpated. That's how. You can't just write it's a non-pulsatile mass.
Okay, sir.
No other masses. What? No other masses. What other masses you are expecting?
Like if there is any metastasis to the liver.
No organomegaly.
No organomegaly.
No organomegaly. So succussion splash. Have we really done succussion splash in your case?
Yes, sir.
What is the prerequisite for succussion splash?
Sir, we should ask the patient. We should ask the patient to drink a glass of water, sir. And we must keep our bell of the stethoscope or even the hand is kept on the epigastric region, sir. And we give a slight shake. We slightly shake the patient, and we can feel if there is any gurgling sound in the epigastric region, sir.
Even if you do it on me also, I will also have the same.
So
you make me drink water and you shake me, you will get a gurgling sound on me also maybe.
Yes, sir.
So that means I also have gastric outlet obstruction.
No, sir. We should wait for the gastric emptying also, sir.
What is the normal gastric emptying time?
3 to 4 hours, sir.
It's for solids. For liquids, it's almost 2 hours. Okay.
2 hours. Yes, sir.
Okay, fine. So that's why be careful while telling all those things.
Yes, sir.
Not wrong. Okay, not wrong. You can still substantiate. Okay, why there is a succussion splash? Because there is a distension of abdomen. Okay?
Distension of
normally there is no distension, so there cannot be well heard. Normal stomach. No organomegaly. Hernial orifices are intact, not free. Hernial orifices are intact, and external genital is normal, and back is also normal on palpation. Renal angles, the spine, everything on palpation is normal. Next.
Yes, sir.
Percussion.
On percussion, there is impaired normal resonance over the abdomen, but impaired resonance is felt over the mass. There is no shifting dullness or fluid thrill. The liver span was about 12 centimeters, and the upper border of the liver dullness is noted in the 5th intercostal space, sir.
What is this normal resonance over the abdomen? What kind of dullness? What kind of note you get on a stomach usually?
We usually get
normal
a
tympanic. Abdomen. Okay, fine. Sorry. Okay, normal resonance over the abdomen, except for the liver dullness, splenic dullness, whatever. And what is this impart resonance over the mass?
So because it is an intra-abdominal mass, there will be impaired resonance on percussion, sir. Whereas if there is any, if the mass lies behind the colon, there will be resonant note over the mass.
Resonant only, not impaired. It will resonate. If a colon is there
In case of a
above,
stomach mass,
if any colon is there above stomach,
no, sir.
then
No.
you could palpate the mass, means that is it is just below the skin.
Yes.
Then okay, so usually you get altered
Usually
resonance
the-
because there are two medias. Okay, there is gas also there, liquid also there, also there will be solid also. Okay, mass. So you'll get altered resonance.
Okay, sir.
Okay.
Altered resonance.
We don't write
Okay.
this. No shifting dullness or fluid thrill. When do you get fluid thrill?
If there is a free fluid in the abdomen for more than 1.5 or 2 liters.
No. Nothing like that. In a child, children also 1.5 to 2 liters. Huh?
No, sir.
For everyone, it's 1.5 to
Adult?
2 liters. Huh?
No, sir.
No. So then what's the criteria? Fluid thrill is seen in only one condition, that is 10 societies.
10 cells.
We don't know quality, but only 10 societies only you get fluid thrill. That should be the criteria, correct? Is there 10
Yes, sir.
societies here, or a lot of distension is there in abdomen?
No, sir. No.
Then not possible to, then what's the need to write fluid thrill here?
Okay,
It means that you have knowledge but no application. Shifting the no, instead of shifting dullness fluid thrill, you can write there is no evidence of any free fluid in the abdomen.
Okay, sir.
Clear?
Yes,
Next.
sir.
Next.
On auscultoscraping test, there is a change in the note heard when the scraping below umbilicus. There is no arterial bruit or venous hum is heard, sir.
It is mainly a ausculto percussion test, mainly done to
Yes,
look, for the distension of the how much it is distended.
Distension of the abdomen.
Ladies, there are no USG and all. That time they were dependent on this. But these two important tests, they will be asked in the exams. What is succussion splash and what is ausculto percussion? Not just knowing the theory part of it, but you should know how to demonstrate also. Many of you will be caught when asked to demonstrate. You might have not done during your clinicals, but in exam suddenly you'll be caught. So don't do that. Practice, okay, for the patient. So okay, what is Bates test?
So Bates test is done to find out if there is any pseudocyst of pancreas.
How?
I don't remember.
What do you do in Bates? You put a Ryle's tube.
Okay, sir.
Ryle's tube, okay, nasogastric tube, and then you can palpate the Ryle's tube over the just below the skin, subcutaneously.
Yes.
Why? Because behind what is there? Big what is it? Pancreatic pseudocyst is there. That is pushing the stomach anteriorly. So stomach is almost collapsed, and it is just below the skin.
Okay.
So Ryle's tube is inside the stomach. So if you just palpate the skin, you can feel for that. What is that? Ryle's tube. It's called Bates test.
Bates test. Okay.
Next. Next.
On digital rectal examination. On digital rectal examination, the rectal to rule out if there is any rectovesical pouch deposits, sir. Bloomer's shelf is ruled out, sir.
Okay. Also, any constipation? Any constipation is there? Okay, any hard feces are there because of this dehydrate? That also you can make this. Okay.
Okay.
You can also look for any 58 unlikely, but still prostatomegaly can be made out with the digital rectal examination.
Okay.
And immediately you should take out and see, look for the staining on the glove, any blood stained, any
stain. Yes, sir.
That's important. Other systems are essentially normal. Okay. So
normal.
Next.
Yes, sir.
Next.
This is my summary, sir.
Okay. Okay. Next. The patient is a case of gastric outlet obstruction, most probably due to carcinoma of the stomach. Okay. Now, what are the differential diagnoses?
So for this case, the differential diagnosis could be a chronic duodenal ulcer with cicatrization, sir.
Very good.
And there could be a chronic pancreatitis may be present in this patient, sir. And
Mhm.
there could be a gastric lymphoma or a gastrointestinal stromal tumor may be present, sir.
Mhm. Mhm.
And
Any malignant etiology that is done. You need not to tell the pathology or pathological diagnosis. Anything else?
okay, sir.
Carcinoma, anything else? Any other carcinoma?
Carcinoma head of the pancreas may be present, sir.
Okay. Any other benign conditions? Have you asked for any his mental status? Anything?
No, like trichobezoar, there is no trichobezoar or phytobezoar, sir. His mental status is stable.
Okay, fine. What is Wilkie's disease?
Wilkie's disease is compression of the superior mesenteric artery, sir. Usually the angle between the aorta and the superior mesenteric artery is 45 degrees, sir. If the angle becomes less than 22 degrees due to sudden weight loss, there will be Wilkie's syndrome, or also known as nutcracker syndrome, sir.
Compression of superior mesenteric artery or duodenum?
Duodenum, sir. Due to
Between?
decrease in angle, sir.
Between what and what? It
The
sandwich
superior
between,
mesenteric artery and the aorta, sir.
not aorta. Posteriorly, what is there?
Um,
Vertebra?
yes, sir.
Okay.
The third part of the duodenum will be compressed.
Yeah, exactly. Third part of the duodenum. So,
Yes.
okay. Next. How do we manage this case?
So first of all, I would like to resuscitate the patient, sir.
So there are
Because-
gastric obstruction, most probably carcinoma of stomach, and there are no features of any metastasis. You can write.
Yes. Okay, sir.
What is early gastric carcinoma?
Early gastric carcinoma is defined as carcinoma involving the mucosa and the submucosa, irrespective of the nodal status, sir.
Very good. Very good. So how do we manage this case?
So in this case, because since there is gastric outlet obstruction due to a distal growth, I would like to do a lower radical gastrectomy.
Come
With
on. Aakash, so far you answered really well. Now you are, I think, hypoglycemic or sleepy. I don't know. Don't suddenly go into the surgery, man.
Okay.
There's so many things to be done.
Yes, sir.
Management means investigation
first
and treatment.
investigation.
Okay.
Yes. Sorry,
You
sir.
still cannot
Yes, sir.
confirm. Do you have ultrasound eyes and what to say? Huh?
Oh,
So we have to confirm. What is the investigation? So that's a tricky
Yes.
way of asking. Instead of asking you what are the investigation you do, then how do we go about? How do you manage? We know you. This is the common
Okay,
mistake you do. That's why we want to put a trap for you. That's why we ask like that.
Okay.
Okay.
So
Don't
first
fall
of
into
all,
the
I would
trap.
like Yes.
What is the investigation you want to do?
My preferred investigation would be a upper GI endoscopy, sir.
Mm-hmm. Why?
And then so that we can be able to visualize the lesion and also take a biopsy, sir, and also see the
Both,
extent of the lesion.
Yeah, both diagnostic as well as therapeutic also sometimes.
Therapeutic.
Okay. Okay. Then what are the features in upper GI endoscopy?
So we can look at the extent of
In the
the
benign and malignant ulcers.
Yes, sir. In case of a benign ulcer, there will be a loss of convergence towards the ulcer. Sorry, sir. There will be loss of convergence in a malignant ulcer, whereas the convergence will be present in a benign ulcer. And in endoscopy, there will be loss of rugae in the malignant ulcer, whereas the rugae will be present in a benign ulcer. The size of the ulcer will vary, sir. More than 2 centimeters or 3 centimeters, it is a malignant ulcer, whereas less than that, it will be usually it is a benign ulcer, sir. And if the ulcer is placed on the greater curvature, it is
Okay,
a malignant
okay.
origin, unless
That
proved
theory
otherwise. Sir.
you read. What are the drawbacks of this upper
Yes,
GI
sir.
endoscopy? What are the drawbacks? You understood?
Sir, yes, sir. In case of diffuse type of cancer, we cannot be able to diagnose the case. In case of linitis plastica, we may not be able to diagnose.
Why?
So because there will be loss of distensibility of the stomach, sir.
That's why we cannot diagnose. So no, why cannot see? I'll give you example like linitis plastica, GIST, lymphomas, carcinoids. All this we cannot
Yes.
diagnose through upper GI endoscopy. Why? Because the mucosa remains normal. All this happen in the submucosal plane.
Yes. Mucus.
Correct?
Yes, sir.
Huh?
Correct.
Correct?
Yes.
Huh? That's why.
Yes,
Okay.
sir.
So before upper GI endoscopy, what do you want to do?
So we can do a barium meal study, sir, in such
No,
cases.
stomach wash. That's important. Okay. Stomach wash is
Stomach
necessary.
gastric lavage. Yes.
Stomach lavage, gastric lavage is important. Okay. Thorough. Otherwise, all the
Yes,
food
sir.
particles there, you cannot visualize anything. What are the complications of
Yes.
upper GI endoscopy?
So there may be uh, bleeding, sir, due to trauma, and
Next, further trauma can lead to what? Viscera.
it can lead to perforation, sir. Iatrogenic
Okay.
perforation may occur, sir.
Okay. So mainly these two. Okay. So
Yes.
what other investigations? One is upper GI endoscopy.
Next, to stage the disease, I would like to do ultrasound of the stomach, sir.
Mm-hmm.
In
Okay.
ultrasound, we can look at
lymph status and all you can make out. Okay. Next.
yes. Then we have to do a
Any
contrast
free fluid is
enhanced
there you can
CT.
make out with USG.
Yes, sir,
Next.
in the USG. With the help of contrast enhanced CT, we can measure the tumor thickness and whether it is adherent to any other structures, sir, which will determine its resectability.
The gold
We'll
standard
do a,
investigation.
sir,
What is the investigation of choice?
upper GI endoscopy, sir.
No. For this, what is that? You told the spread and all to look for.
So contrast enhanced CT of the abdomen and pelvis and thorax, sir.
That is for distant metastasis and all. What about the local spread? The stomach.
Endoscopic ultrasound can be done, sir.
The best. That's the best. Okay.
Yes. Yes, sir.
So all the 5 layers can be differentiated very
Differentiated.
well. So what the extent of the involvement you can make out through EUS. Okay. What
Yes.
is the role of X-ray?
So X-ray, we can look for any chest metastasis, sir. But nowadays we do it with CT of the chest, sir. Thorax.
X-ray means only chest X-ray. Didn't tell.
Okay, sir.
X-ray is both plain X-ray and contrast X-ray is also there.
Yes, sir. In case of contrast, we can do a barium meal study, sir.
Using
barium sulfate contrast, sir.
very good. I wanted that word because barium acid is a very neurotoxic substance. Okay.
Yes, sir.
But barium
Yes.
sulfate is a very soluble substance. Okay.
Yes, sir.
Microcrystals of barium sulfate we use, but not barium phosphate. Remember, it's barium sulfate. Okay.
Barium sulfate.
We ask them
Yes,
to drink the solution of the microcrystals of barium sulfate, and then we, using fluoroscopy or X-ray, we take the images. What are the
yes,
features you can
sir,
get
we
in
can
barium?
delayed emptying, so we can see, sir. And if there is any ulcer, the ulcer can be delineated, sir. And we can also see the distension of the abdomen, sir. And we can also see
what next? But linitis plastica, what type of deformity and all will be there? It's best. Nowadays, the indication for this thing is mainly that linitis plastica only. Okay.
Yes, sir. We can see a teapot or hourglass deformity, sir.
Okay, hourglass contracture. Very good. Next, what are other indications for barium meal nowadays? Only 2-3 indications are there. One is I told you, linitis plastic.
Yes.
Second thing, any gastrojejunal fistulas.
Okay, sir.
Okay, any gastrojejunal fistulas. And one more thing is the hiatus hernia.
Hiatus hernia. Okay, sir.
Okay. Remember, it's gastrojejunal only. It's not gastrocolonic. Gastrocolonic cannot be. For that, you need enema, barium enema, because colon is a high pressure zone. From there, it passes the fluid to the small bowel, okay, or the stomach. So for gastrocolic, you need barium enema,
Barium
whereas
enema.
gastrojejunal you use this
Barium.
barium meal. Okay,
Okay.
that's about the barium. Read very important. And these X-rays will be kept in your Viva, right? Akash, you had
Yes, sir.
these images in your.
Yes, sir. Yes, sir. We had. Sir.
Okay, so you will have rat tail appearance, that parrot beak appearance. All these usually they keep as spotters in your Viva, so you should not
Yes, sir.
miss. So one definitely
Okay.
one barium study will be there. So read everything about barium studies, different barium studies. So next, what's
Okay.
the other any blood investigations you want to do, or in tumor
So-
markers?
We can do a carcinoembryonic antigen tumor marker can be seen, sir.
Okay, what's the treatment?
So since this is a distal growth, I would like to do a lower radical
So,
gastrectomy.
one trick here is before directly
sir.
moving on to surgery, you should tell that one answer, sir. I want to optimize the patient before
Optimize. Yes,
any
sir.
further treatment. First, here is the
Yes.
optimization because he's continuously vomiting. There's a low BP. There is dehydration. All so many things, anemia. So many things are there. You can't directly go for surgery. Okay, surgery
Okay,
will be successful, but patient will be dead on table.
Okay. Sir.
So okay, so
Yes.
you need to optimize the patient. These are all the tricks
Yes, sir.
which examiner will ploy on you. Okay, so
Yes, sir.
so how do you optimize the patient of gastric outlet obstruction?
So since the patient is dehydrated, I would like to start him on normal saline, sir, IV fluids. Then we have to correct the deranged fluids and electrolytes, sir. And once the urine output is normal, we have to give a potassium chloride, sir. And then since the patient is also anemic and he will also have hyperproteinemia, we should start him on total parenteral nutrition, sir.
Okay. Anyway, he's optimized. Then what next?
Then we should plan for the surgery, sir.
What surgery?
I want to
Straight away
do a
surgery,
low.
or you want to do anything else before surgery? What's the role of chemotherapy? The role of neoadjuvant chemotherapy?
Yes, sir. We can give a regimen of cisplatin, adriamycin, or epirubicin and docetaxel, sir, to downstage the disease and decrease the size of the mass. First 3 cycles is usually given, sir, initially. Then if the mass is downstage, then we can go for the surgery, sir. And following the surgery, the remaining 3 to 4 cycles should be completed, sir.
Okay. Surgery, what do you do? What surgery you do?
Sir, it is a lower. Sorry, sir.
Correct. Tell me, for distal growth, distal mass, you do?
Yes, sir. For a distal mass, we do a lower subtotal radical gastrectomy with a proximal margin of 6 centimeters and a distal margin of 1 centimeter with D2 lymphadenectomy and reconstruction with Roux-en-Y gastrojejunal anastomosis, sir.
Very good. For proximal ones?
For proximal cancers, we do a total gastrectomy, sir.
Okay. And leave it like that?
No, sir. We do a gastrojejunal anastomosis.
Where is the gastro? You don't total gastrectomy, then where is the gastro?
Esophageal duodenal gastrectomy. Yes.
Okay, fine. What is D2 gastrectomy?
Sir, in case of D2 gastrectomy, we remove the stomach along with the mass and we remove the lesser. Yes, sir. D2
what
lymph
D1,
nodes.
what is D2, what is D3?
Yes, sir. D1 consists of lymph nodes from 1 to 6 stations, sir. D2 consists of 7 to 11.
Very gastric lymph nodes.
Yes, sir, gastric lymph nodes. And then D2 consists of lymph nodes surrounding the major vessels, sir. And D3 consists of metastatic nodes, sir.
Okay, good. What is the difference between irresectability and inoperability?
Sir, in case of inoperability,
so the question will be for you, only UGs, the question will be, what are the signs of inoperability?
Yes, sir.
What are the signs?
Here, signs of inoperability are presence of ascites, sir, and presence of Krukenberg's tumor, and other lymph nodal enlargement like the Trocheus sign, Sister Mary Joseph nodule, and fixity of the mass to other ends of the mass to the surrounding structures, sir, and iris nodule, and
So in one line, what you can say? Any signs of distant metastasis?
distant metastasis.
One
Yes,
line. Okay, any signs of distant metastasis are there, or if it is adherent, or if it is infiltrating into the some vital organs. If you can remove
Yes.
like skin or pancreas, it's okay. If it's into aorta and all, can you remove?
No, sir.
It's become irresectable.
Yes, sir.
Clear? Any role
Yes,
of
sir.
radiotherapy?
Radiotherapy, I don't know, sir.
We don't give usually radiotherapy in carcinoma stomach because all the radio resistant okay, it's usually radio resistant, and some radio sensitive organs are behind that, behind
Okay,
the stomach bed. So that's why we
Yes,
don't
sir.
give radiotherapy in case of carcinoma stomach. There's a role of
Yes.
immunotherapy, but nowadays immunotherapy is
Okay.
coming. Okay, some drugs are.
Okay, sir.
So
Yes, sir.
what are the complications after this surgery?
Complications
Read
like
about all those things. I'm not going to detail. What is Bill Roth's 1? What is Bill Roth's 2? What is how it's
Yes, sir.
better from how it's better? Ru and Y is better than all those. What are the common
Yes, sir.
complications of Bill Roth 1 and 2? Okay, all
Okay.
those things
Yes,
you
sir.
read. And what are the complications of this again? Ru and Y gastrojejanostomy. Okay,
Yes, sir.
and all about surgery. How much length? What is the length of the Ru limb you keep? Why is
50
that? So why
centimeters.
to leave
Yes.
40 centimeters of a Ru limb? Okay, to
Okay, sir.
prevent reflux or
Bile
biliary
reflex. Yes, sir.
okay, and
Yes, sir.
all the things. What is EMD?
Sir?
What is EMD?
Uh,
Endoscopic?
uh,
EMR. Early, yeah.
endoscopic mucosal resection, sir.
Okay, it's for early cancers.
Early gastric cancer.
Differentiated and very small, less than 2 centimeters in size, only involving mucosa and submucosa. You can do early mucosal resection.
Early mucosal.
Okay,
Endoscopic
endoscopic
mucosal.
Okay,
Yes, sir.
that's the one. And what are the palliative surgeries? You know.
So palliative, we can do a Devine's exclusion procedure, sir, and pyloroplasty can be done, sir.
Palliative mainly 3 things. One is to improve the nutrition level, that is okay, to feed him either by stenting the stomach or the pylorus, or by doing some feeding jejunostomy. Okay, that's the one way of this thing. Second thing is mainly to relieve the vomiting. Okay,
Yes,
and
sir.
third thing to relieve the pain.
Yes, sir.
These are the things. And what else? Questions? Yeah, palliative surgeries you should know. That's it. That's all about almost everything about the carcinoma stomach. Anything to be covered, discussed, Aakash?
No, sir.
You tell me. Anything left out? You
No,
prepared
nothing.
much than me.
No, sir.
Huh? You know everything, man. You know nothing to ask you actually. Okay. I'm so happy. Okay, for undergraduate level, you answered and you performed really well. Okay, you have a bright future.
Thank you, sir.
And
Thank you, sir.
please be assured about a very good result in your exams also. Okay, so
Thank you, sir.
please be the best doctor. Okay, aim
Yes,
to be
sir.
the best doctor. Okay,
Yes, sir.
that's all. Okay, all the best and wishing
Thank
all the
you, sir.
success. Very well
Thank you
presented,
so much, sir.
and because
Thank
of
you,
your
sir.
well prepared presentation, many of us could learn many new things from you, and also we could learn a lot from you. Actually, all the students also. Okay, so keep presenting.
Yes,
I really appreciate. Even after exams, you are presenting like this. It's very something unique I've seen. Okay, in so many
Yes.
years, my experience. So great.
Thank you, sir.
This will help a lot for all of us. Thank you once again. And so
Thank you,
many
sir.
active members are attending this late, attending Aakash presentation. On behalf of Aakash and myself, we thank all the active members, participants who patiently listen to Aakash and also my scoldings. And was I so harsh?
No, sir. No, sir.
That's how I teach. Okay, I seem to be little, what to say, harsh or what, strict, but I'm not that. Okay,
Yes, sir.
to study something we need to be little serious. Okay, that's
Correct,
why
sir.
I act
Yes,
as if I'm a bit serious. Okay, but I'm not like that.
Okay, sir.
Yeah. Any help, anytime,
sir.
please let us know. Okay.
Yes, sir.
Get a PG seat soon. Do your internship well and PG seat soon.
Thank you, sir. Thank you,
Okay.
sir.
Good night.
Good night, sir. Thank you so much, sir.
And send me the corrected PPT. Okay, I'll share it in the Telegram. Okay, all
Okay,
the
sir.
corrections I told you, make it and send me. Okay, I'll next you will be going to present one any important soft tissue sarcoma or any parotid or which are not done, oral cavity cancers, anything you present. You're
Okay, sir.
really good. You're really good.